Hello, everybody, and welcome to a new ECOS webinar, part of our webinar series, Cancer Mission Impact, the Practitioner Series, Learn, Test, and Come Back. My name is Marius Geanta. I'm the co-founder and the president of the Center for Innovation in Medicine. Work package lead in the ECOS project. ECOS stands for Establishing the Cancer Mission Hubs, Networks, and Synergies. The project aims to support the creation of the National Cancer Mission Hubs in EU member states and associated countries. The topic of our today webinar is transforming cancer care from the ground up. And as you will see, it's a webinar organized in very close collaboration with the City Cancer Challenge. And I'm very happy to briefly introduce you the speakers of our today's webinar, starting with Isabel Mestres, is the CEO of the CCAN. Sophie Bussmann Kemdjo is the Regional Director for Europe and Africa at CCAN. And Natia Verdzadze is the CCAN Project Manager and former City Manager in Tbilisi in Georgia. So first of all, and Harold Kotin from CCAN is joining us as well. So I'm very happy to have you with us today in this webinar. As you know from our previous webinars, we will start by some keynote presentations from Isabel, from Sophie, and Natia, and then we'll continue with the discussion with the audience. So I encourage you to ask your questions and to put your comments in the Q&A section here in Zoom. And we'll proceed with you, Isabel, for the first presentation. And thank you so much once again for being with us today.
Thank you so much, Marius. Can you hear me well?
Yes.
Okay, so welcome everybody. I would like to thank Marius and the ECOS and all of you to invite us here. You know, we're really pleased to be able to share our model, and of course, you know, after we have questions, but after we remain available to make sure that if there's things that spark your attention and you want to know more, please follow up with our team. So I'm going to start by giving you a bit of background of why City Cancer Challenge. What is City Cancer Challenge? And always the question, why cities? Which is a question that has followed us since the very beginning. And hopefully now we've overcome that question, but we still have many of those questions. So I'm Isabel Mestres. I'm from Barcelona originally, but I lived in Switzerland. And previous to City Cancer Challenge, I was the Director of Membership and Partnership at the Union for International Cancer Control, which is sort of the largest cancer membership organization. And in that role there, back in 7 years ago, there was we were doing a lot of advocacy to bring cancer into the global agenda. There's a lot of push for national cancer control plans. There's a lot of push still on it and on cancer registries. But we were seeing little progress in the ground. We've also gone through the last 20 years, massive innovation, a lot of advances on breast cancer, lung cancer, many others, as well as in technology diagnostics. But we're not seeing this innovation reaching the most vulnerable. And again, not only LMIC, and I think part of the conversation today, also reaching some of our, you know, more rural or villages or cities across Europe. Equities are everywhere. So why? Is it that we need to invest more on innovation, or is it the systems that are not ready? So that's where we come in, on the system readiness. We're also seeing, again, a lot of planning, but those plans being on shelves. Things were not going into implementation. A lot of understanding of what works in high-income countries. We've seen there's a lot of research and evidence, mainly based in high settings, signed by high-income country authors, very little know-how on other settings. And again, we cannot translate what works in a country like Switzerland. Maybe I don't have the fact, but more or less, let's say it's around 10,000 euros per person per year per health. Is not comparable for an $80 per person per year in Kenya. So what works in this high context doesn't work in a context like Kenya. So what are the interventions that actually are going to change the course in this type of settings. And that's the evidence that we need. And that, again, applies also for low resource settings among Europe. So with those questions and those premises, we wanted to get action. We've also seen in a lot of interventions, most of the interventions, because of the global funding, the donors were pushing funding in those low resource settings towards communicable diseases. There's been a lot of attention around primary healthcare, but very little attention around the cross-systemic approach. So the early detection, the diagnostics, the treatment, and there was a huge gap in that cancer care aspect, and more in the prevention side and more attention on the primary healthcare, which important, very little attention was on the other side. We were also seeing a lot of silos interventions. Also, again, mainly driven by donors. For example, we've seen a lot of interventions on screening. We know screening works, but it works when you have a follow-up, when you have a referral pathway, when you have access to a diagnostic. So is an intervention on screening an adequate intervention? It depends if you have the other things in it. So we were going here like, we need to address or avoid silos intervention. We also need to start looking more from a systemic and less from a disease angle, which is another of the things we've been doing over the last year that haven't changed the systems or that haven't transformed the system. So how we go for a more systemic approach, less silo, across diseases. So it's complex, and cancer is complex. It's a lot of layers. So that's where talking with the environmental health organizations, also talking a lot with the HIV community, they were saying, Isabel, if you want change happens at local level. That's where the data is, where the workforce is, where the patients are. You need to go local. But what local means for cancer? I mean, local means what? So then we've agreed that our minimum viable product would be a city. And that's where the confusion comes in. Traditionally, we've addressed cancer care from a national perspective because of the complexity, because of the tertiary. But what is a national system? It's complex, it's fragmented, it's many different systems in one. It's the public, the private, the military, different paying system, the insurance. So if you go to a city and you see a city as a microcosm that reflects a national system in a smaller scale, then you can start targeting the system, because then a patient doesn't navigate in a country, but a patient, if you think about the day citizens, not the night citizens, that go from a primary healthcare from a rural area or from a district beyond the city, they go to the city maybe to get radiotherapy. So if you start seeing where the patient navigates across the system, then you can start at least understanding what are the gaps in the system. So that's why we work with cities. And I think that you have to see, again, a city as a defined territory that helps us visualize primary, secondary, tertiary, help us visualize private, public, and other systems that might exist, help us visualize what is the workforce development, help us visualize the data that is generated, the flow of the patient, so we can capture data, systemic data. And we can see the flow in the system, because as you can see, if you go into one institution, which is another aspect, maybe that institution says, I need a PET CT. Well, but if you actually zoom to the city, maybe that institution doesn't need a PET CT because there's one around the corner, 30% utilized. So it's elevating the bird eye enough to generate understanding of the system. And that's why we're working with cities. And when we talk about cities, don't think about the mayor. The mayor is one important person, brings a lot of attention, brings us together. But the city is the national government that has power on that city. Different in any place, but there is some power in terms of policy. You have the regional government, also part of the city. You have any institution, any decision-making in that territory is a stakeholder for us. So that goes from patient organizations to hospital directors, to labs, to universities, to payers, insurance, whatever institutions have that country that affects that city. And for us, those are the stakeholders that we involve. So we have a model that my colleague Sophie will present to you, but I really wanted to understand that it's a model that works. It's a model that allows us to generate data, and it's a model that is starting to transform also the national landscape. And that's something we didn't expect. We were more focusing on getting things done, understanding what were the best interventions to improve access to cancer care. But what we realized is that by identifying those gaps, that data, we're bringing light to the national government to understand what were the policies that need to require review, improvement, or actually getting them done. So you will see we have systemic data, is data around the services available, the quality of the services, the management of the services, the data, the health workforce development capacity, as well as the accessibility of the data. And we don't only bring the institution's perspective, we also bring the patient perspective. And of course, you can imagine that sometimes it's not the same perspective, but it's super important to bring that. And we'll talk more about that, because one interesting aspect we've done in one of our cities in Rosario was when we collected data and we bring the patient perspective, we involve the students from the medical universities. And that was a way for the students to start understanding the importance of listening to the community, listen to the patients to understand what are the gaps in that system. And that was actually quite transformative for those students, which are the future leaders on the healthcare. So I think with that, I'm just going to say we are in 15 cities. It's a model that we're trying to scale, but equally we're trying to go deep. So in the cities we stay, actually we're committed now. We started wishing to stay 3 years. There is no outcomes in 3 years. This is a long game. So we're staying for at least 10 years. Because we actually have now, and we could talk about that a bit later, we have an impact framework to measure impact. So we're going to actually looking for outcomes and then be able to tell the world what interventions work and which didn't work, so that we can all target best interventions towards patient outcomes. So I'll stop here and I'll pass it to Sophie to go deep in the model.
Thank you very much, Isabel. This was very inspiring, as always, and a lot of energy. Harold, would you please share the slide? Thank you. Okay, so yeah, as Isa was saying, the place where you live does not, should not dictate the type of care that you receive. Next slide, please, Harold. And this is a question of equity on the global space, and also to create, some socioeconomic challenges that we see because of people migration, because of health issues. And this also kind of break barriers, because if we have to also support how the migrations, this angle particularly is the mobility of people and helping people, supporting people in where they are, and ensuring this equity will also allow more equity at the global level. And as a blank, starting as a program back in 2017 on a blank page, CCAN is a registered Swiss organization since 2019. And we can proudly say, as Isabel Wasio was mentioning, that as we speak today, we are proudly in 15 cities across the globe and counting. There is a current due diligence process that is ongoing for us to expand the network. For now, we are already present on significantly in Latin America. That is where we have our biggest contingents of cities, and also the city where we actually started testing the program, and to see that this model is working. We are also in Africa, in the Africa region, as you see on the dots. We are in Asia and also in Eastern Europe. So as I said, the network is growing. We're looking at sharing this approach to as many cities in the globe as possible as an incremental process, and also hoping, the end point for us is that, as we mentioned, we are also addressing the city. We are looking at scaling up at the national level, and also creating this cross-city fertilization where we're moving stakeholders around to share about their best practices and make sure that a network, a broader network is benefiting, and that the benefits are lasting in terms of this ownership at the local level. So how does the model work? our model is really around 6 main pillars. I will see here one very centric element is people, because when we talk health, we're talking people, we're talking it's not just about processes, it's not just about infrastructure, but really making sure that we're putting the people at the center. We also have system thinking, as Isabel was saying, because having cancer as an entry point allow to support this health system strengthening, because it's a complex disease that includes so many other different specialities around that allow to fix the system. We are locally led, which means that even if we're Swiss-based, the program is actually executed at the local level. So it's a really needs-based approach that we have. So the solutions that we develop are not developed from a top-down approach, really from the ground up, meaning that they are identified as needs and then transform into solution, and more importantly, delivered by the local with the support from the international experts to ensure this international standard. The data-driven approach in our model is also very important, because there's no decision that can be taken without the right data. And this right data that we are also giving here start from the needs assessment phase. That is really a thorough assessment where we actually assess the ecosystem of cancer in the city. And based on that, they inform the type of solution that we are actually supporting the city to develop, and also the decision-making that are being taken at the national level based on the data that is provided by the model. And then, of course, the multi-sectoral partnership, and this start really from the bringing all of the partners locally together, to private sector, civil society, and patient organization, the government's very essential, because we're talking about policy making here, so they are very essential in the process. So all of the parties that are really have vested interest in addressing cancer care in the country are involved, and also multi-sectoral in terms of the type of funding that we aim to provide in the city to support our work. And last but not least, the knowledge sharing. Knowledge is power, and by sharing knowledge, we make sure that there's no duplication of effort. We're not reinventing the wheel, and all the partners and also at the local level know about what have been done, the results, so that they don't repeat the mistakes. And we really capture the learning to make sure that the progress is made on past learnings, and not repeating the same testing and the same piloting something, as we hear sometimes in the development world with pilots, but the pilots are based on pilots, and at the end, if you don't share, you can having the same pilot. So our model is really to make sure that that knowledge sharing is happening, to make sure to ensure that there is progress and not repeats. Next, how. So our engagement process is by phase. As our CEO was mentioning earlier, it was a 3 to 5 years approach, divided in, I would say, 3 main blocks in terms of learning, empowering, executing. And as we have noticed, health is more complex and long-term in terms of outcome. So our program is now going to a longer periods, but I would say that the first part is very important, in that it creates the foundation to be able to actually ensure that there's multiple cycle of intervention in the city, in the sense that when we are actually, when the city is accepted, apply to join the city cancer network and have gone through the due diligence, there is a significant stakeholder engagement phase that allow us to read the ecosystem, understand who are the players in the cancer care ecosystem in that specific city, where is the power, where is the power in the city, who are the people who are actually shaking, doing, what are the forces that are actually driving the ecosystem, to make sure that we capture them and make sure that they are all united around the table to actually support the initiative that is being rolled out. And as I mentioned earlier, we have the need assessment, which is really a citywide process that takes a lot of energy, a lot of time, but this is a very, very important step in our process, because it allows this massive mobilization of the key players that we have identified earlier, and to work on how is it on infrastructure, in the infrastructure for cancer care, how is the policy environment, what is the data in terms of infrastructure, what is the data in terms of the quality of care, the perception from the patient. I mean, there's a lot of dimensions that is really looked after here in terms of the facilities that are providing cancer cares, and then also the laboratories, and every institution in the city that has something to do with cancer care is mobilized and consulted, and we collect data. So just to give an example, through at the current moment, we're going through due diligence in Abuja, and in I would say in a span of 2 weeks, we were being able to mobilize over 400 patients to collect data on their experience in terms of how they navigate the system in cancer care. And that will actually be a tremendous amount of data that will inform the next step of the stage. There will be also some questionnaires that will be be applying to the healthcare facilities, to the laboratories, other partners. And based on this data, we have analyzed them and identify what are the main pressing issues, and go into the next phase of prioritizing them with the city, and also coming up with a strategic planning of what is it that is important for the city. So we don't take that decision. It's really a decision that lies with the city in terms of when we identify, let's say we come up with over 50 priority area. They're not strategic yet. Are you going to address all of it? What is the time frame? What is the resource available at city level? And based on this type of parameters, we go into the next phase of saying, we narrow down the funnel and decide in conjunction with the city, the Ministry of Health included, what are the projects that we believe in the time frame ahead of us and the resource available we can implement in the city. So in general, there's an average of 10 projects that come out of that process for prioritization. This is the case for Nairobi, where currently we have about 11 projects, and 11 projects with a few outputs, an average of 2 to 3. And this is the same process that goes in cities. They come out with the respective project. And once that is validated at the city level by the executive committee, that will be addressed by Natia in terms of the Tbilisi case specifically in Europe, how that gets into the project development that is worked on by the project teams in the city, to make sure that they actually take into account the context, the reality of the ground, and really that ownership that is important in terms of how they come out with this implementation of the project. So an implementation project would mean, let's say the case of one project that could be on radiotherapy, a long-term development plan on 5-10 years, and that plan is including the level of capacity development, the level of infrastructure that is needed, the level of quality assurance that is needed. And based on that, they come out with a robust roadmap for how good would looks like in the 5-10 years in the radiotherapy. That becomes a bankable document for the city to be able to mobilize resource and implement the content of that long-term development plan. And when we are about to have completed the project in the city, at some point, let's say 3 to 5 years after having started in the city, we have a phase where we actually assess and evaluate, are we successful? Of course, there is interim assessment throughout the process in the previous periods, but at the end of that completion, where we have the project ahead of us completed, we sit with the city and say how much is completed, how successful has the resource mobilization been in terms of the previous periods, but the appetite from partners to follow the implementation in the second cycle. There is, the critical part is the local political commitment to say what we have been producing before. Let's say the multidisciplinary care approach that is established in the city. Has there been a resolution passed? How much is this adopted by the government? These are also critical criteria for us to say there has been work done in the country. There has been some political commitment that is required. Have they done their part of the work? Because at the end of the day, we are actually just providing a framework. So if the adoption doesn't happen locally, this will be an element for us not to be keen to go in the next cycle, because this is not automatic. It has to be based on the willingness of the locals to actually have the recognition of the work they're doing and seek that political endorsement, have that policy dimension that is contributing to the success and the sustainability of previous projects, to be able for us to say, we can actually mobilize these resources with you and continue a second cycle of intervention. So this is really a moment. They have been in the natural course of an organization like ours. There's sometimes difficult decision, because you will say you have to stop the program because there are the main criteria you require are not there to be able to go into the next phase. It's difficult, but it's also an opportunity in the sense that it allows to go in new places to actually provide the type of support when that they're asking for, and their readiness that is actually factored in. So really this and the second cycle kind of correspond to a bit of the same process as in the first. So just that there is a legacy from the previous periods. The network is known. We have project teams that have been identifying the people. It's like either reducing or increasing, but usually the second cycle, as an example, we have here, we are traveling to Tbilisi in February for a design workshop in the context of a very successful first engagement phase in the city. And now we're going into a global implementation at the national level in Georgia, based on this success that we have had. So the design will allow us, in collaboration with the Ministry of Health of Georgia, to define exactly what are the activities, the timeline, and then the joint work in terms of creating this mobilization that will allow sustainability of the project also in Georgia. Next, Harold. Yes, as I mentioned earlier, in terms of this multi-sectoral approach, we usually follow the same process in all our cities to create a government body that is a city executive committee that actually takes all the decisions in the city pertaining to the initiative. They are the one who give us guidance in terms of, are we going in the right direction with the projects? Are we undertaking the right activities? And before we move from one important milestone to another, they have to actually endorse and approve that the previous phase has been okay, and that they agree that we can move on in terms of the direction that we're taking with the project. So here it's the keywords are really about collaboration. They're local. They actually have that local leadership. They ensure the knowledge exchange within the city. They actually make sure that the advocacy is happening, and they are the decision-making bodies. And this, as you see here in the boxes, represent from government side, Ministry of Health, the municipality government, to the civic society, the cancer registry, the private sector in terms of the insurance providers, also you have the public and private hospital, patient advocates, academia, very important as well. So really it's I would say a matrix of experts that will ensure that we have the integrity of the process, and that we're really working based on the contextualization and addressing the different angle, because they all contribute to have a robust solution at the end of the process. Next, Harold. So this is a bit of a complex table, but it was to showcase how much the executive committee has that leadership role in the city. And then underneath, and as part of the executive committee, we make sure that we have technical committee members who are specialists in the different areas. So we have here the 4 core areas that we look into when we're working in terms of defining the solution in the city, from management and quality of cancer, the core cancer diagnostic services, core cancer treatment services, community patient access lead. And in this different group, we create working group, we create the committees for this specific, I would say, core areas, and then working groups that will work and they can be massive. The working group have a size that can be very sizable, just to mention in terms of making sure that all of the stakeholder groups that we are talking about in this here to make it multi-sectoral are involved. No one is left out, and that at the end of the process, there's no group that is challenging the needs, either the needs that are identified or the type of solution that are being developed and the outputs that are actually delivered at the end, because we make sure that in the whole continuum of the process, you have all of the the sectors that are involved, and also creating this reinforced ecosystem, because one of the things that we have noticed in this low and middle income environment where we operate is that there is a lot of fragmentation. Sometimes the actors are in the city, they're doing their work in the silos. They know each other because they have been to school sometimes. They have some friendship that is established, but professionally, there is no this cohesion that exists. And one of the one of the best compliment and validation that we can get as an organization. And it's when in Georgia, for example, we had this recognition from the ministries that has been telling us before CCAN, we didn't have this cohesive group that is working. And thanks to CCAN, clearly we are seeing here now that the healthcare professional and the governments and civil society are working together around a shared purpose to make cancer care, improve the cancer care space in the country. So this is a testimony of this model working, and it's not the only place we have been giving this feedback. We know that the model works and we play that role. Next and last slide for my side, I think. It was the last slide. So yes, in terms of the detail, I will let Natia, who is our Tbilisi city manager here, go through the Tbilisi specific rollout of the initiative. She's also our Global Breast Cancer Initiative project manager. Over to you, Natia.
Thank you, Sophie. So now let me present experience from Tbilisi to show how we implement the process in practice that has been described very well, I think. Tbilisi's journey with City Cancer Challenge officially began in February 2019 with the signing of Memorandum of Understanding. And over the several years, the city underwent a transformative process, which included mapping key stakeholders, conducting a comprehensive needs assessment in collaboration with local leaders and experts, and organizing multiple committee meetings to analyze challenges and identify priority actions, and of course, the consistent growth of local commitment. As part of the immediate response to the need, in 2019, the government of Georgia announced the expansion of the list of the cancer medicines covered by the Universal Healthcare Program with an increase of the annual limit. Next slide, please. So the second initiative in each city has the city governance, as Sophie described. It is the group of people who actually lead the process. The Tbilisi City Executive Committee was launched in 2020, and the group was composed of the Deputy Minister of Health, Director General of NCDC, Head of Healthcare and Social Services of Tbilisi City Hall, leading cancer care experts and advocates representing diverse institutions, patient organizations. The CC leads and monitors planning and implementation process of the whole project, the whole initiative. Next slide, please. So how do the project development process go? So urgent needs are being prioritized by the local stakeholders as they know the context, local context very well, and based on the needs assessment conducted before that. And project teams are being developed, created, who lead the implementation of each project. And to dive more into the projects that has been implemented in Tbilisi, I would like to start with the Cycle 1 program, which included 9 projects and around 30 outputs. And to start with the, for example, education and training project, which included the development of the recommendations for pre- and postgraduate programs to strengthen them, and to develop electronic program for primary healthcare doctors on early signs and symptoms of cancer. Cancer registry, which included development of the manual on how to provide the data in the cancer registry, assessment of the whole registry process, and to carry out the technical concrete actions to ensure the completeness of the registry. Pathology and imaging to standardize the diagnostic services, quality of cancer care to strengthen the MDT approach and to adapt the cancer management guidelines. Diagnostic reimbursement project. As you may know, diagnostic services are not financed by the Universal Healthcare Program in Georgia, so it was requested by the Ministry of Health. And with the support of CCAN and PwC, a project team identified diagnostic tests for all cancer types, which has to be funded by the program, and also the budget has been calculated. The results have been presented to the Ministry of Health with the purpose to support them to take informative decisions on cancer diagnostic reimbursement, which is in progress for now. And requirements for quality cancer care. The project team visited Catalan Oncology Center in Barcelona to learn about the best practices for cancer care regulations. As a result, the team developed the recommendations for requirements for systemic treatment and oncosurgery. And as for the systemic treatment, recommended requirements included establishment of central pharmacy inside the hospitals in accordance with international standards, and which has been immediately considered by Ministry of Health, which means that the medicines are now delivered to the patients directly in the medical institutions, and the quality of systemic treatment service has been improved. Next slide, please. So now I would like to stop your attention to the key achievements and opportunities. To start with the key achievements, as I have mentioned, there is the expanded list of the medicines funded by the Universal Healthcare Program, increased annual financial limit, creation of the oncology pharmacies inside the hospitals, development of the breast cancer action plan for Tbilisi that I will mention later, adopted cancer management guidelines, development and adaptation of cancer diagnostic and treatment development plans, and development of electronic module for primary healthcare doctors on early signs and symptoms. And the opportunities. Strengthened multi-sectoral collaboration. So by engaging different sectors, including local stakeholders, ministries of health, and international technical partners, this type of partnership promotes a multi-sectoral approach focused on cancer care, which facilitates the integration of projects into existing health systems, ensuring a sustainable ground for long-term success. Knowledge generation and dissemination, collecting all the lessons learned and all the best practices from the projects creates a robust evidence base. The knowledge can guide the development of policies, programs, and implementation strategies for cities and countries. And enhanced data utilization. Pragmatic research studies and monitoring frameworks embedded within city projects generate valuable real-world data on cancer care. And this data supports evidence-based decision-making, enables precise interventions, and facilitates the scaling of effective models. Next slide, please. So let's continue with the key capacity development activities provided to Tbilisi as the opportunity to strengthen different areas of cancer care. To start with the international collaboration for research methods development in oncology workshop in India. And the goal was to provide researchers with comprehensive training in various aspects of clinical trial design, and to help them to develop their research ideas into structured protocols. One click, please. Yes. SEED grant, the researchers are investigating health system research projects that are specifically related to cancer care in the cities where they work. And of course, Tbilisi was part of it. The researchers aim to conduct studies on early stage research, collect preliminary data, and so on. The visit in the Catalan Oncology Center that I have already mentioned, and this visit ended up with the transformative result for Tbilisi. During cycle 1, 25 health specialists in pathology, medical imaging, surgery, medical oncology, radiation oncology, nurses, palliative care specialists visited international reference centers in Europe to gain practical international work experience in their areas of expertise. SICAN and ASCO, American Society of Clinical Oncology, collaborate to strengthen the capacity of mid-career women oncologists in SICAN cities to drive impact change in cancer care. And one of the medical oncologists from Tbilisi was participating in this program, and as an immediate result, she became the director of one of the leading hospitals soon after the completion of the program. Another collaboration of SICAN and ASCO is to implement a multidisciplinary cancer management course in Tbilisi to strengthen the multidisciplinary approach in cancer care. And the last one that I want to mention as a capacity development activity is that in December 2023, with the participation of Georgian Ministry of Health, SICAN and WHO convened first workshop through which key Georgian stakeholders based in Tbilisi provided input about the current care delivery in alignment with the Global Breast Cancer Initiative framework pillars. This framework is to provide guidance for policy makers and the medical community in resource constrained settings on how best to adapt existing healthcare resources to optimize patient outcomes. Breast Cancer Action Plan was a result of this workshop, and it was afterwards it was presented to the Ministry of Health with the national scale-up purposes. Next slide, please. And with all this, we are entering the cycle 2. The second cycle of the SICAN Technical Cooperation Program in Tbilisi has been developed in collaboration with all relevant stakeholders in both the city and country levels, and was informed by 2 strategic activities. The first one was the scoping visit after the successful completion of the first cycle to reassess the city's needs. And the other was the Global Breast Cancer Initiative workshop that I have just mentioned. And so those 2 key activities informed the Cycle 2 program, which aims to enhance cancer care services in the city by leveraging local and international expertise, resources, and partnerships. And this approach ensures the alignment of project activities with desired outcomes and long-term impacts. 3 thematic areas have been prioritized for Tbilisi Cycle 2 program, which are improvement of early cancer diagnostics, ensuring quality and timely cancer diagnosis, and enhancement of cancer care quality. And we hope that cycle 2 for Tbilisi will be as successful as was the first one. Thank you.
Wow, thank you very much for your presentation. It was such a pleasure and inspiration actually to hear you all. And indeed, as one of our attendees mentioned in the chat, this is the mission on cancer applied to real context. This is very clear. And first of all, thank you, Isabel, for answering really concrete some of the questions in the Q&A. Thank you so much for that. Indeed, a very good interaction today in the ECOS webinar. And we have around 15 minutes from this webinar and a lot of questions, but I will try to structure the questions. You are acting in low-middle income countries, but our understanding is that this framework you presented can be basically used in a lot of regions from the high-income countries. And if we are looking to many, I would say, EU member states, we can see a lot of inequalities between different EU regions. So that's why we think this is so relevant for ECOS and for the EU Cancer Mission. Your project is so relevant for us. And my first question is, what are, I don't know, the main lessons you extracted from your experience that might be of interest or useful for the cancer mission implementation in different EU member states at the regional and local level? Yes, Isabel.
So I was trying to type all the answers. So it's a bit of like the lessons learned. No, I think that the first thing is that we have to stop fearing bringing stakeholders together, because it seems sometimes very difficult and exhausting, and how we do all this stakeholder engagement. And we have to stop fearing. And if I use the example of COVID in my own city in Barcelona, I remember how the healthcare community actually, without even thinking, they start coordinating themselves. They set up these early 7 a.m. meetings between all the hospitals. It was a natural thing to do in a crisis situation. And they all make it happen. They organize themselves. Actually, the government came late to those meetings. Like they joined it after weeks. So I think this bringing the stakeholders together is something that we have to stop fearing, because it's really appreciated. And we've seen that actually they sometimes don't know each other. And you're like, what do you mean? You're not talking, you're not coordinating. It's just, we're human. We need to engage, we need to talk. So I think it's like bringing them together. And of course, you always need a neutral partner to make sure that it's truly, and it's about a lot of building trust. And again, it seems like a fashionable word. No, we have to build trust. Well, yeah, let's do it. I mean, building trust is an exercise where you can actually make sure that everybody brings to the table their interest, find that common interest. What brings us together? What are all of us interest on? And make sure that then that's what brings us together, and not look into the things that bring us apart. And then if you bring data to the table, that also generates a lot of trust, because you try to ensure that those special interests are not conflicting. So with the data and a lot of work in stakeholder engagement and really understanding, what are their motivations, what are their passion, and how we can all make it work, because it's visible in every city. We've done it. But it's true that is what we get more questions about. And I'm always surprised, like, what do you know? I mean, you're struggling with stakeholder engagement. We find that easy because we do it. And it's like, it's just do it. I know it's like very Nike, but just bring them together, open, and just be very honest that it's not going to be an easy ride. 100%. We're going to do mistakes. You're going to get upset. And we're here for the bigger good. We're here to make sure that this city can actually support cancer patients. We all agree with that. So let's move and let's accept failures. Let's accept that there is personal interest, but which that not stop us. So I think that's, I would say, a very practical thing that we've learned, that it works everywhere. And yes, we have a lot of work to make sure everybody. And the other thing is to make sure that everything that's happening is well documented, because if not, we enter into duplications. There's a lot of initiatives already happening, and sometimes we don't know. If you go to a country like Tanzania with a lot of international focus, sometimes there are like a lot of cervical cancer projects just competing one to another one, and they're not maximizing resources. So it's important to take the time to analyze the landscape. Who is the decision maker, who is doing what initiative, what is that initiative, and start to bring all those initiatives together and make sure that they are all part of a bigger goal, and it's not a thing that we're like losing resources. And it's important to bring in the table the 3 layers of government. I know it's very difficult, but once you bring them together and you show them that actually they can make a change working together on this with all the other political battles, this is it comes across as it's not a battle that's stopping them apart. So it's also when you nail that political commitment from the 3 layers of government, then a lot of things were smooth. I have to say a big learning is the National Ministry of Health. That cannot be ignored in every our cities. That's a critical one when we exactly go to implementation, making sure that everything gets implemented and for policy change. And I know we have so many lessons. Also, we have failures. We can spend hours here.
Yeah, let's continue with the issue of trust, but moving towards engaging the patients and the citizens. And one of the learnings from our experience is this very high level of stigma and fatalism when it comes to cancer. And maybe you can share some lessons how to tackle this, how you engage with the patients, with the families, with the communities, you know, to build the trust.
I think Natia has very real examples.
Thank you. So I have to say that patients are heart of SICAN initiative. And like, as we have mentioned, the aim of SICAN initiative is to improve patient outcomes. And most important is that we want to improve patient outcomes with them, with patients. They should be part of this process, and we make sure that they are part of this process. Patient organizations are invited in each phase of project implementation or planning or real implementation phase, starting even with the needs assessment phase. There is always space for patients to identify the needs in each city, and the project planning as a following step. They are invited to each of the meetings dedicated to planning. And of course, in the implementation phase, there are some projects which are led by patients. For example, the advocacy programs for better quality of cancer care. And I think this ensures that the voices of patients are central to program design and implementation. And also, one thing is important to mention, that the city executive committees that are, as we have mentioned, leading the process, patient organizations are part of this group of people. So making sure that patient organizations are participating in every CEC meetings with policy-making people, which potentially, of course, translates the voices into the actionable policies and practices. And we think that this platform of City Executive Committee helps to bring them patients, the specialists, and the decision-making people, brings them closer and helps to understand each other better.
Thank you for your answer, Natia. So I think we covered the challenges when it comes to stakeholder engagement, patient engagement, citizen engagement, governance, really important. You, Isabel, you mentioned, and it's normal, you know, different stakeholders to have different priorities, and sometimes the political landscape put a heavy pressure on different initiatives. But we have, I think, a really solid framework at SICAN developed in years. And you mentioned in your presentation that in order to measure impact, we should wait a few years. So how do you manage the expectation? And I mentioned the policymaker, politicians, they they sometimes look for something like immediate results. So what is the framework to evaluate the impact you are using in CCAN?
Sorry, I was pulled out. I don't know. I've missed something.
Yeah, me too.
Me too.
Yeah.
Okay.
It was a technical.
I was, yeah, I think was a technical issue, but I will come back to the question. So the question was, how do you manage the expectations of the decision makers or politicians? They might expect to have like an immediate result, but we need more time. And in this regard, how do you manage this? And what is the way you measure the impact in CCAN, let's say short, medium, long term?
Managing expectations is very hard, specifically because the process there is not a, how you say, we're not using card shots, like we're not using fast ways or fast wins. Of course, we do sometimes do a few projects there with quick wins to make sure that the government, extends engaged. But this is a long-term game, and that's why it works. And we're not saying here, so of course we have a set of, at the beginning we have sort of process indicators, like how many people are engaged, how many patients are engaged, how many projects have been developed, how many projects with budget or investable, how many. It's like very process-oriented indicators. Then we go into outputs indicators. So then we go into outputs, sort of like how many quality assurance programs, how many guidelines have been developed and adopted by the government, how many, diagnostic plans, sort of like those, how many workshops, how many trainings, more of those outputs. And that we can see outputs, year 2, year 3. And then as we go into multiple cycles of implementations, as Sophie said at the beginning, we cannot jump, as if sometimes like, how we bring AI. I'm like, oh, there's not even data infrastructure. Like, don't jump. There is first, let's set up the policy for data. How there is data, find the data, consolidate it. So it's like we go into that. And then, of course, we have now a framework that I have to say that one of my biggest challenge when we started CCAN was what good looks like. Because I haven't seen any publication on how we measure, what are the outcomes that say what quality is, access is, equity is. There is none. And actually, that's why we engage with the Richard Sullivan, with the King's College, the International Cancer Policy Institute, and WHO say, guys, we need indicators. So actually, we've been working with them on developing quality indicators for cancer care. And I'm happy to share all that work we're doing with the university, because that is it's helping us to know what are we measuring. And of course, the publications we're doing are generic outcomes indicators. We cannot measure all of them in our countries because we're working at city level. So then we have a framework of cities. So we're able to measure things as of today, like a reduction from time from suspicion to diagnostic, or from diagnostic to treatment. We're able to measure abandonment rates reduction. We're able to measure like early staging or down staging. We're able to measure maybe the quality or the time, like the surgery was repeated or not. There's things that we're now able to measure. And I think we are also testing those indicators in the ground, because nobody has been able to test it. I mean, in the settings I'm working, of course there are in Europe, I'm sure, but not in the settings, because of the data it's not there. But we are actually developing also our own digital solutions, because without those digital solutions, we will not be able to generate the data to see if we're actually reducing time from diagnostic or treatment. And we have, great examples in Kigali. We managed to reduce it from 82 days to 28 days in a very short time. And it's just like, this is the type of things that then suddenly the government says, okay, this is a good investment. It's like patient navigation. It's a no-brainer for this context. Because it really, but we need to, so expectations is hard. Let me tell you, people think we come, because we're in Geneva, we come with a lot of money. And that is not the case. There's no funding available for cancer at a global level. And now for anything, let's put it. So we rely, there was a question, we rely a lot on private sector funding, some philanthropy funding. But we're actually, that's money for us and to support the locals to go through the process. But what we need to make them see is that actually getting the data, planning, project development, the costing, that is what's going to make them bring the money. And we're seeing that. We're seeing many cities that actually are opening domestic resources because they brought the evidence to the national government, but also we're able to crack deals with the World Bank, with IFC, because we have the data and the evidence of what is needed and how it's going to happen. And I think they start to click, but it takes time because they want quick wins. So yeah, we trick sometimes and look for solutions to quick wins. Like we know that capacity development is something that we can deliver fast. So we tend to accelerate some of the projects that we know that at least can maintain the engagement of the stakeholders.
Yes, indeed, it would be great to if you can share your work with Richard Sullivan. This is so important, and we are experiencing from cancer primary prevention projects, part of the cancer mission, quite the same challenge because going at the community level, you don't have the right frameworks to assess the impact of different intervention and so on. So this would be really great and informative. And of course, I have hundreds of questions, but I will ask you a final one. And partially you asked Isabel on the scaling up of your solution. You mentioned in the chat that this cannot be applied to mega cities, but what about small towns? What about rural areas and so on?
Yeah, so for the rural areas, it's when we're talking about systemic approach, is difficult because they don't tend to have a radiotherapy unit, or we have to find the place. So how we're working, for example, in Kigali is that we started in Kigali where you have the 5 main center treatments, but then we start going, once that is sorted, and we have another colleague that run this project that actually then went outside of the city, more towards the districts outside of the city and go further to make sure that then is how we connect, for example, diagnostic projects. So it's like, do we need to bring people to the city for diagnostic? Not all diagnostics. So how we then generate networks of diagnostics in the city? How do we connect with the primary healthcare system? So the first point. So maybe patients don't need to be supervised by treatment. So we do once the city, then we go into the network in terms of like setting up networks to referral, like for example, how we train primary healthcare on signs and symptoms, but how from that rural area goes into the city if they need for one. So there's projects around networks for labs, for example, for referrals, for different things. But we start at the city and then we go up to see, okay, who goes to that city? And then we tackle that and make sure that things then get distributed because sometimes there's unnecessary bottlenecks. And not everything has to go to the city. There's a lot of things that can happen in those rural areas, but then you need to understand the data, what's available in the city, and then start from there going to see where the patients come. But we're not going to a little town. It's not a good return investment, and it would not be a systemic approach. There's other solutions, but they have to be part of the conversation, and they are part of the conversation.
Absolutely agree. So I think it was a really great webinar, and thank you so much for sharing with us so many details. As I mentioned at the beginning, at ECOS, we are supporting the creation of the National Cancer Mission Hubs. And you at CCAN, you actually presented how the future of the National Cancer Mission Hubs and implementation at local, regional level could look like. So thank you very much for driving us into the future. This was really great. And another comment before passing the floor to you, Isabel, is that there are so many similarities between the frameworks you presented today on stakeholder engagement, how to approach citizens and patients, the cycles, and this is so close to the concept of the living lab we are working with in the cancer mission. So many similarities, and this is really great and build a foundation for future joint activities. And yes, Isabel.
Thank you. No, Marisa, I just want to thank you, of course, for hosting us and everybody, because part of our mission is Sophie is sharing knowledge. And so we want to share as much as possible our model because we see it works very well. Of course, we've also learned failures, and we're also happy to share those failures so that we don't do it again. And again, we're very focused on low or low middle income countries. However, over the years, we've realized that we've generated a lot of assets, frameworks, education that would apply for any country. So we're more than welcome if any of the hubs needs support. If they can reach out, we can always see how we can also share some of those assets with them. Equally, we're working a lot with a few cities in Europe for capacity development. So for example, with Barcelona, we have a great relationship with all the different hospitals there, and they actually the ones that are supporting, for example, Georgia. There's a really good connection there. And I have to say that people from Barcelona are probably getting as much as people from Georgia, and that's the feedback they gave, because they see other ways of doing it, other ways that are much more efficient because of the low resources. They have to be more creative. So that exchange of knowledge is something very, very beneficial also for countries in Europe to engage with us as, like sister cities between us, one of our cities and their cities. So that's the offer, the sisters, but also the support for your hubs and our assets.
Yeah, offer accepted from our side. And indeed, as we are here to have a real impact in people affected by cancer lives. Thank you once again, and I think this was on the first step of our collaboration. So we stay close, we'll share the developments, and at the end, thank you so much to the people from the audience and for the great interaction again in this ECOS webinar. Have a good day and all the best.
Thank you.
Thank you. Bye.
Thank you. Bye-bye.